they're not good anaerobic coverage and it's limited. But so the theory with combining is a little bit of it could be location specific. So if you know your quinolones have a low sensitivity for a lot of your gram negatives and gram positives, so if you look at your anti-biogram, it's all coming back, you may want to add double coverage. If you know you have good coverage for your like hot organisms, so, and again, it's mostly gram positives, right? Then you may be able to use single coverage. So it's a little bit of weighing stewardship and protection. So it would, I don't know, I'd have to look at LexiComp source and their plus minus about their citations sometimes. I'll look into it and I'll get back to you. I'll post an announcement to the class.
Okay.
Okay.
Thank you.
Go ahead, Ryan, and then I'm going to comment on what Dr. Fox just said too.
Okay. Yeah. So when we were talking about that earlier in your video, on the slides, it says plus as well. And so that's why I didn't know which direction.
I think that was my fault. I wasn't intending it as a combination. I was intending it as those are the preferred agents versus Clinda, which is an alternative.
Gotcha.
Yeah, and I can
tell you formatting, unfortunate formatting.
Yeah. And I can tell you that in practice too, I sort of make the decision based on, again, the local infection rates, antibiogram. I also make a decision based on if the person lives with children, young children who are going to school, and if I'm concerned that there may be additional coverage, bug coverage that I need. But in general, we try to minimize the risk of C. diff in these patients by not giving them double antibiotics if we think that we can reasonably cover with just the one empiric agent. Because they're at much higher risk for C. diff. Because unfortunately, they're coming into infusion centers, they're going to a lot of doctors' offices, they're getting their blood drawn. So their risk of exposure is much higher. So I hope that helps too for some context.
Thank you.
Any other questions about that before we move on to question 1? Okay, so my goal with these first couple questions was really to get you guys exposed to some of the different ways that you might see these labs reported, because this is very, very institution and lab specific. So looking at labs from Quest is different than looking at things that are in Epic or Meditech or Cerner. And it's also dependent on how your individual lab wants to report things. So that was my goal, and that's why I asked you to do the same calculation basically like 4 times. Because I don't know, you guys are going to go on Appies in like a minute, hopefully, fingers crossed. And you're going to be looking at different labs at least 6 or 7 different places, and they'll probably mostly be different. So this first one, I don't know, personally, I feel like reporting in percent values is a little bit less common. And I think it tends to be I see a little bit more in like outpatient type lab settings. And so this is the way you can calculate ANC when things are reported in percent. So what did people come up with for question 1?
$396.
Did anyone get anything that was not 396? Or very close to that, plus minus a little rounding? Yeah, so the answer was 396. I'm hoping these will be pretty straightforward, cut and dry. And can we move on to question 2?
Yes.
Dr. Label, will you scroll for me? All right, so I find this one to be a bit more common in patient setting as the method of reporting. So what did people come up with? And I think this is a pretty easy calculation, so I kind of like it when it's reported like this. So what did people come up with for question 2?
400.
Anyone come up with anything that was not 400? $400, yeah, it's 400. So it's pretty easy. I would say most places tend to report as segs and bands, so that's kind of pretty easy to be looking out for, and kind of what I would expect you to be looking for if you were my student and we were on rotation. Good to move on from question 2, or any questions about that?
Good to go.
Okay. So this is a more comprehensive lab panel. So you don't have to calculate ANC if the labs are reported like this. So they're already written out for you. So which one is ANC? Which value? I'll have to look through your later. Yeah, that's correct. So that one with the little star. So that absolute neutrophils, that's the 5th from the bottom. So that's already done for you. So 3.1 is the way that it's reported. So, and that's essentially, you'll have to do a little calculation if you want to see if that's, under 500. But it's nice when it's reported like this because you don't have to do really any math. It's pretty straightforward. And so is this patient neutropenic or non-neutropenic at this time?
Non-neutropenic?
Yeah, it's correct. It's also easy because this lab has flags and reporting. So if they were neutropenic, it would be highlighted in red and have that little L in the flag section. So this is like labs light is what I like to call it. You really have to do minimal interpretation. The things you have to be careful when you have labs light is it can flag for things that aren't really clinically relevant. So for example, you look at platelet count. So 150 is considered like the minimum normal value. And this patient in this lab has 149,000 platelets. And so is that really relevant? You'd have to really look at your patient and decide if that was a relevant lab that needed action or can just be monitored at the next lab draw. Depending on when that is, might influence your choice. If this is an inpatient and they're getting daily or every other day labs, you could probably just wait it out and see. If this was something that was trending down, it might require action. So labs light is good, but it can require a little bit more advanced level of interpretation because and documentation. It really comes into documentation because when things are so obviously flagged like this, you have to document what action you took or chose not to take in response to those labs and why. Any questions about that?
Do the ANC lab values change from different hospitals? Like, do they have different protocols?
The way that they present them and occasionally the standard range can vary slightly. Generally, it's pretty close or pretty similar. ANC, I would say, is less likely to fluctuate. It does depend a little bit. So creatinine clearance is a big one. There's 2 major ways to calculate serum creatinine and then therefore creatinine clearance. And what method your lab uses to identify serum creatinine in the serum can depend on what creatinine clearance calculation you should use. And the only way you'll know that is by calling the lab. It's really annoying. But in a bit more advanced, it's kind of, if you have a patient you really want to know their creatinine clearance a little more accurately, because it can cause your calculation to vary by about 20%. In general, the reference ranges are pretty similar, but they can vary.
Okay.
Yeah. And for some of my patients, so I generally use Epic. And most of the systems that I've used will provide you with an ANC calculation already. Like it'll just have it dropped in with your CBC with diff. When I will calculate by hand, is it sometimes the ANC that's listed is a little bit higher than the actual ANC. And so if I have a situation where I'm worried about like truly, treating somebody, like if it's a treatment decision, or if they're kind of borderline, I might do the hand calculation and then I'll go with whatever the lower value is always, because that's the safest way to operate in this circumstance.
Okay, thank you.
And so what you might not know from here is, so absolute neutrophil count is what ANC stands for. So occasionally some labs, when you order CBC with diff, they will literally count the neutrophils and report that. Other times they'll take the diff values and do a calculation. So it's important, it can be important to you, if that's part of your responsibilities, to know if your lab is reporting a literal count or a calculation. And that's usually just something you have to ask the lab.
Okay, thank you.
Any other questions about question 3? All right, let's keep it rolling. Okay, so this was how labs reported at the last hospital I worked at. We had Meditech, and we had pretty ancient lab equipment. So this is probably the least common, I would say, way of reporting that I've seen, at least. So what are the 2 values that you need, or I should say, what are the 3 values you need from this chart to calculate a patient's ANC?
PMNs and bands. And
PMNs and bands, and what else?
And white blood
BBC?
cells.
And white blood cells. So what are PMNs? What does that stand for?
It's like a type of smaller white blood cells.
Yeah. So it's a one of the like early types of white blood cells. So they're polymorphonuclear leukocytes, or PMNs, which it's like missing an entire letter from the name, but sure, why not? And so it's a similar way to report your segmented neutrophils, basically. So it's kind of like another name for your segs. So in this case, what method of calculation would you use of the 2 or 3 that you guys have practiced so far?
I use the one similar to the one in question 1.
Yeah, so the one in question 1 is the most appropriate for calculating in this question. And what did you guys get for a result?
17,370.
Yeah. So this patient is not neutropenic, obviously. This patient these are from a patient who had endocarditis. So these are someone who is having a fulminant immune response to bacteria. Any questions about calculating using this method or when labs look like this? Awesome.
All right, moving on to Adrian Meissen. Hope you guys appreciated that little bit of chemo humor. Okay, so before I get to that, I got asked a question regarding the definition of cisgendered male. So it occurs to me that I may have to just very briefly touch on a couple of these definitions so that people understand. Cisgendered means that someone, the body that they're born in is the gender they identify with. So in this case, cis, it's like on the same side from chemistry, right? Versus trans, opposite. Okay. So cisgender just means that this person was born biological male and identifies as a male. If someone is a transgendered male, then that means that the person was born a biological female, but identifies as a male. So, and that may have any number of implications. It could be that someone is taking hormone therapy. It could be that someone is simply openly appearing to people as a male. They don't have to have any surgery or any other kind of interventions. They might just have a male name. They also might be kind of non-binary. So that means they identify biologically as male, even if they were born female. But they're choosing to kind of be open on the spectrum. So, if you ever have questions about, specifically what all those definitions mean, please feel free to reach out to me. I do use trans, cis, people of different orientations, non-binary, etc., in my exam questions. It's really important because your patients are going to not fit into any of the boxes that either you feel more comfortable putting them in or that you're used to them presenting in. Okay, so it's really important to make sure that you understand that patients can come with many different kinds of parts. So some of them may have had, surgeries to transition. Some patients may have just transitioned with hormones, and some patients may be kind of on the fence and not sure, what form of transition they want to take. Bottom line is, if a patient uses a particular pronoun or name to describe themselves, always use that. If you're unclear, ask. I promise you, patients will not be offended if you ask. They will be offended if you use an incorrect term over and over again. And the other thing that's important is that right now with Epic and many of the other EHR systems, they've actually incorporated this language into patient identifiers. So it can be a little bit confusing if you're not kind of paying attention and looking for it. Is everybody good with that? Any questions or comments? Oops. All right.
And most places have opted to put that in the patient header as part of information that you can quickly identify. So it's pretty easy to figure out, at least at most institutions.
Yeah, and the more comfortable you are with these terms, the more comfortable your patients will be about telling you things about their life that could be extremely important, like who their family support is, who their partners are, et cetera, et cetera. So it's really important for us to just be non-judgmental clinicians who are just absorbing information and collecting information as opposed to making any decisions about the information we're getting. So, all right, cool. I'll get off my soapbox now. All right. So we have Adrian Meissen, is a 40-year-old cisgendered male who recently was diagnosed with stage 2 Hodgkin lymphoma, and his oncologist is planning to start him on ABVD, which we will learn in a couple of weeks. But it's adriamycin, bleomycin, vinblastine, and dacarbazine on days 1 and 5 for a total of 6 cycles. Incidentally, how often do we give this regimen? Did you guys look? So if we give it days 1 and 5, every how many days? Or days 1 and 15, how many days?
14 days.
Right, so that's 14 days, but the cycles, if we're giving it day 1 and 15, we're usually doing it like a full cycle would be considered 28 days. It's fine. But just so you know, we're giving it essentially every 2 weeks. It just depends on the institution. Some people count like that as 1 cycle. Some people consider it multiple cycles. It just depends. So for a total of 6 cycles, which is fairly common, sometimes we'll do 4 if patients have a really good response. He's otherwise healthy, so that should signal doesn't have any additional risk factors, right? Okay. So please categorize the risk of febrile neutropenia. So I put a hint here. So let's start with team 5. What did you guys categorize the risk for this regimen? This was kind of a tough one, so it's okay.
We said it's intermediate.
Okay. And what was your rationale behind that?
So we looked up based on like NCCN on the NCCN page guidelines and found the ABVD regimen, and it said it's between 10 to 20%.
And okay, so let me pull up the regimen here. So you're talking about the growth factors guideline?
I think so. Hold on, let me find it again.
Okay, because I'm going to take a little bit of issue with that, but let me pull up the. I have like 10 screens going right now, so. All right, here we go. Here we go. Okay, I'm going to stop sharing this screen and I'm going to share the guidelines for a second. Okay, so this is the high risk. And this is the intermediate risk. So do you see anything for Hodgkin lymphoma on the intermediate risk?
No, I'm looking at the one I currently have. It's almost identical, except it says 2.2, like 2.2013. So I think I have an old one. That might have just been my mistake.
Oh, no, it's okay. It's totally okay. I'm glad you brought that up because, you know, if we're not working with the same information, then it's going to seem like both people are correct, right? So, okay, it's totally fine. So do you want to amend the statement that it's intermediate risk, or do you have anything else to back that up? And it's okay if not. We can pass it on to Team 6. We're here to help each other out. So, Team 6.
No, I'm guessing it's not intermediate risk.
Right. Okay. So let me stop sharing this and let me bring this back here. Okay, so team, let's go back to Team 6. Can you help out Team 5? What was your answer?
We also went with intermediate. Let me just pull it up real quick.
Sure. And did you guys pull the original study? Because I gave you.
Go on that, but we found a different study.
Okay.
Which basically said that patients treated with ABVD were found to have high frequency of neutropenia. However, they're not able to relate the incidence of whether it's because of the chemotherapy administration or something else. So, but based on the patient, looks like they're healthy. Other than getting treatment, they don't really have any other risks. So we were kind of torn between low to intermediate. So we just went with intermediate based on that.
Okay. So further question for you. So you just mentioned that in that study, they talked about kind of higher rates of neutropenia. Did they mention anything about febrile neutropenia?
Oh, yeah. I think I read something. Hold on. I have to pull it back up. Sorry.
No, it's okay. It's okay. I wanted this is meant to be tough. And I did this purposely because I want you guys to really think about, if you didn't know, how would you find this information? Because you will be put in this position during rotations.
So it says incidence of febrile neutropenia is low and unrelated to neutrophil count in Hodgkin's lymphoma treated with ABVD.
Okay.
So we weren't really able to go, to say like for certain whether it is or it isn't. So that's why we went with intermediate. But it sounds like if the patient is healthy, this regimen doesn't necessarily cause febrile neutropenia. Like we weren't able to see that. It does or doesn't.
Yeah, no, I appreciate that. So a couple of things to make sure that, because I'm hearing this from a couple of groups now, when we're looking at the risk for a regimen, that's separate from the risk that we look at for an individual patient. So the first thing we want to do is figure out, independently of this patient, what is the risk factor of febrile neutropenia in patient populations receiving this treatment, okay? So actually, there's a lot of controversy about this, and there has been for years, in part for two reasons. I'll get to one of them in a little bit after we kind of talk about growth factor support. But the first thing is there's not a lot of good information from some of the original studies about the rates of febrile neutropenia. And I kind of alluded to this earlier about saying that in some cases they just talk about grade 3 infections, and then they separate out also neutropenia. So there may not be information about febrile neutropenia. So you might have to make a clinical judgment based on, if you have a lot of grade 3 infections, maybe the risk of this regimen would be higher. So I'm going to show you, actually pulled a couple of different papers through the years just to kind of see. I'm going to stop sharing this and I'm going to share. Okay. So first thing I'm going to do is I'm going to show you how I figure it out using the guidelines. Okay. So I had a let's see here, relatively hard time finding the original papers. Are you able to see the guidelines here?
Yes.
Okay. So what I do is I go to the Hodgkin lymphoma guidelines. So if I don't know anything about a regimen and I'm like, I don't know what the risks are, I have no information, there's no guidance for the, in the NCCN growth factor guidelines. That's why I picked this question, because I wanted you to kind of have to stretch and figure it out. So I go to the guidelines, and then I look to see, if they have the same regimen that I'm looking for. Now, there are going to be some variations, like some are with radiation, some are without. Obviously, that's going to make the risk a little bit different. But the easiest thing is just to pull the first reference that I can find. So then I found this reference, actually. And I see a chat here. Hang on. I think I see a question. Okay. All right. So I'm going to stop sharing this, and I'm going to pull up. Sorry if I'm making anybody car sick here. Not my intention. All right. And I'm going to share with you. Here we go. Okay. Are you able to see this chart here?
Yes.
Okay, great. Yes, go ahead. I heard somebody getting ready to ask a question. Nope. Okay. So this was the paper. I pulled the original paper and I immediately just scrolled down to adverse events according to treatment group. So I'm obviously going to be focusing on just the chemotherapy, right? I'm not worried about the radiation therapy. So I'm looking here and I'm seeing, okay, I don't see febrile neutropenia, right? So I do see leukopenia, which is not necessarily the same thing, right? It's not, doesn't necessarily correlate with infection. I'm looking here and I see, well, okay, there's infection. And the rate of infection appears to be less than 10%. So even though they don't specifically enumerate that there is febrile neutropenia, you can probably correlate and say, all right, based on this, maybe we had about a 4% combined risk of febrile neutropenia. So that, again, that would make the treatment low risk. Does that make sense?
Yes, very nice. Thank you.
Oh, okay, good. All right. So I'm going to stop sharing and I'm going to get back to, and I pulled like 4 or 5 different, like I said, different references. Okay. So based on what I just said, I may have changed your answers, but it's okay. So team 6, so you had decided that this was an intermediate risk, right?
Yes, originally.
Okay. So originally, when you decided that it was an intermediate risk, did you decide to go with growth factors? No, right?
No.
Okay. Yes, this was kind of a trick question. It was designed to make it a little bit tough. So in this case, as you stated really, really nicely, this patient does not have any risk factors. So we took a look at the regimen, determined its risk. We know now that it's probably a low risk. We also know that in addition to that, so less than 10% for a low risk, we don't really worry about prophylaxing patients. If this had been an intermediate risk regimen, we see that this patient doesn't have any additional risk factors. So what's our thought about GCSF prophylaxis? We talked about this in one of the IRAC questions. When would we consider using it for this patient?
If he had the febrile neutropenia.
Exactly.
Since
So
he doesn't have it, we would basically just wait on it until he develops it. Then we can treat him with that GCSF.
exactly. So one of the other pieces of information that's important for you to know, a couple of them. There was many years ago a concern that when we combined GCSFs with bleomycin, which is it's the B in the regimen, that there was an increased risk of pulmonary toxicity. Now, bleomycin is notorious for causing pulmonary toxicity, and it can kill patients because it can cause pulmonary fibrosis and pneumonitis. So because there was a concern that they saw anecdotally some higher rates, for a long time, even though it had been categorized as an intermediate risk, for patients for febrile neutropenia, they were not advocating the use of filgrastim, pegfilgrastim, et cetera. Recently, within the last year or two, there have been a couple of studies that showed really no increase in toxicity. So the rule of thumb for ABVD, especially because it's a really toxic regimen and it just tends to cause neutropenia for patients. Again, not so much febrile neutropenia. We tend to only use GCSFs in this instance in order to keep patients on schedule. Stage 2 Hodgkin lymphoma is very curable, but it's only curable if we continue through the regimen. And we essentially have to tell patients we're going to have to muscle through it in order to give you, a 90% or higher cure rate. So in this case, we try and be aggressive and we avoid the growth factors if we can because of, again, some concern over increased pulmonary toxicity. There's also discussion right now if we should get rid of bleomycin from the regimen and add brentuximab instead. So we'll kind of see over the next couple of years how that plays out. All right. Any questions from that?
I have a quick question.
Sure.
So I also read the fact that for this type of lymphoma, we do high dose intensity ABVD because just like you told right now, I consider that as dose dense therapy, which is one of the risk factors to give Neupogen. So like I took it that way that, this is a risk factor because we give it dose dense therapy and that's why I would give this patient prophylactic. Mm-hmm. That's my answer for my tBat, but I don't know I'm right or wrong. I just wanted to clarify on it.
Yeah, no, and I'm really glad you brought that up because dose dense and dose intensity are two different things, right? So dose dense means we're not waiting for someone to recover. We're just hitting them at a shortened interval than we would have otherwise. So the example that we like to use is adriamycin and Cytoxan, or AC, can be given and used to be given every 21 days to allow someone to recover from nadir, right? Because you have the peak and then you have the valley and then you have to recover up to the peak again before you can have your next cycle. For breast cancer now, we use dose-dense AC, so we give it every 14 days, and we're not allowing someone to recover, so we have to give them medications, growth factors, to help artificially bolster and prevent them from getting into nadir, okay? Dose intensity is different. Dose intensity means we want to continue at the same dose for as long as we possibly can to help increase the chance of killing off all the cells in their different cell cycles. Does that make sense?
Yeah. I didn't know previously that those two things are different. I thought it's the same.
Yeah, no, that's okay. And I'm really glad you asked that question, because they sound like they should be the same thing. But really, dose intensity is just, we're not going to be dose reducing patients for something like a hematological toxicity, of which neutropenia is a major one. So thank you for asking that question. I hope that probably clarified things for some of your classmates as well. And
Okay.
that was a good way to think about it.
Yeah, so now I would like to change my recommendation.
Okay, wonderful. That's good. That's good. All right, so let's move on. If everyone's okay, we'll move on to 6, and then we'll get you out of here. All right, so now he calls your clinic 4 days before day 15 of cycle 2, complaining of fatigue, chills, and a temperature of 38 degrees for the past several hours. Degrees centigrade, sorry. He has also developed a mild dry cough and some minor chest tightness. He has a home health nurse coming to flush his PICC line. Does everyone know what a PICC line is? Yeah? Okay. And request to have stat labs drawn. You receive a call from the lab with critical result, and his labs are as follows. So based on this, team 4, does AM meet the criteria for febrile neutropenia? Why or why not?
We said yes, patient meet the criteria for febrile neutropenia because patient has had a fever of 38 for past several hours, and his ANC is less than 500, which is like 450.
Exactly. Perfect. Now, incidentally, I made this case, I added a couple of symptoms. Before we get down into the pathogen, especially now with everything happening, what other pathogen might I be concerned about the patient exhibiting signs and symptoms of?
Team 4?
Yes, please.
So we said gram positive, they are more common.
Mm-hmm.
And as patient have PICC line, so it might be Staph aureus. Like patient might have bacteremia. That's what we were thinking.
Mm-hmm.
Because of PICC.
Yeah, no, and that's excellent. And what I'm going to do in a minute is I'm going to pass you off or have Dr. Fox kind of take over this section. One of the things I wanted you to think about, though, is a fever and a mild dry cough with minor chest tightness. Right now.
Oh, pneumonia.
Well, pneumonia, right. But right now, what other potential pathogen are we really concerned about since we're dealing with a pandemic?
Oh, viruses?
Yes.
All here online instead of in the classroom.
Yes.
Viruses?
Yes, and specifically what virus?
Coronavirus?
Yeah.
Thank you.
Ding, ding, ding. That's right.
Coronavirus.
And
Okay.
the reason why I say this is because Dr. Fox and I were talking about this while you guys were, I think you were in your breakout rooms or breakup rooms, right? Because it never works. We were talking about the fact that unfortunately right now, the total deaths in the global deaths, it appears as though about 20% of those deaths are related to cancer patients. Oh. So this is a huge concern for my population of patients right now who are dealing with bone marrow suppression, either from chemotherapy, radiation therapy, or because of their cancer itself. So one of the things I want you to start thinking of is, yes, of course, gram positives, staph, think of with the PICC line. But the first thing I think of when I see this is, is there a possibility that this patient could also have COVID-19? And if that's the case, then this becomes very serious very fast, right?
Mm-hmm.
Okay, so I'm going to hand back off to Dr. Fox.
All right, Team 4, thanks for identifying that the patient had a PICC line and was at risk of Staph aureus. That's definitely a big concern, which was, probably why this home health nurse was coming in to look at the PICC and get some stat labs. And then you also did correctly pick up on that with this dry cough and chest tightness, there is a possibility of some type of pneumonia. And if we think like way back to when I taught you guys LRTI, it was like the second week of class. It feels like 10 years ago now. What are some of the common causative organisms for pneumonia? And this time I'm going to ask team 8.
H. influenzae and strep pneumoniae.
Mm-hmm. Yeah. So H. influenzae, strep pneumoniae, rarely Klebsiella, and you can also have, other respiratory viruses like coronavirus can also cause pneumonia. So what are some of the, again, to team 8, what are some of the diagnostic information you would want to obtain for this patient? For his infectious workup, we'll say that.
Chest x-ray, maybe?
Yeah. Chest x-ray, and they're portable chest x-rays, so this could be done at home. He wouldn't necessarily have to come in. That's pretty easy to do. You wouldn't necessarily have to make him come out either. It's a little bit harder to do a portable at home. It's a little bit easier if you're at a clinic or at somewhere, but it's not impossible to get one at home. So anything else besides chest x-ray for diagnostic workup for infectious conditions?
We also put blood culture and gram stain.
Blood culture and gram stain, yep. Anything else, or is that the extent of your workup for this patient?
That was what we had so far.
Yeah. Those are probably going to be pretty high yields. It could be helpful if it's feasible to get an MRSA nasal swab so that you can quickly discontinue if you start vancomycin for the patient. It's not predictive for having an infection, but it is very predictive for if the patient's likely to have MRSA once they are infected. So if they have a positive nasal swab, there's a high likelihood that they will have an MRSA infection if Staph aureus is your causative infectious organism. So if the patient is negative and you have empirically started vancomycin, at that time you can discontinue vancomycin if the nasal swab is negative. Did any other teams add or order any additional diagnostic information for the infectious workup?
We said sputum.
Okay. Yeah, sputum culture, induced sputum would be good, especially if you think that the patient has potentially pneumonia. Anything else from any other team? So for this patient, I would have also ordered a urinalysis with a reflex to culture if that was possible, and also strep urine antigen. That can be one way that you can identify, because again, we talked about, and this was like so long ago, but induced sputum can be challenging and can occasionally be low yield. So you can do Legionella and strep urinary antigen, which can help you identify potentially a causative pathogen. It's less useful in pneumonia cases, but it's more useful in meningitis cases. But it could be helpful, and they're cheap and easy. Home health nurses, she can get patient to pee in a cup pretty, easily, pretty low effort. So I probably would have also added a urinalysis and urine culture. Again, in my video, we talked about the fact that 20% of patients usually will have, or more, will have no identified organism. So you want to do a pretty broad, even if, this patient has some symptoms, so we kind of have a good idea of what it might be. You want to do a really broad workup to see if there's any other infections hiding anywhere. And you might have low yield from your site. So you're going to want to pretty much try to hit everything as much as possible. at least everything that's kind of easy and low effort. It might not be worth it to do like a lumbar puncture at this point, but anything that's kind of low effort to do would be appropriate in this case. Team 10, non-infectious workup. Did you guys want any additional labs or diagnostic information that were not related to infections, so more health status?
Maybe a metabolic panel.
Yeah, what are you looking for with that?
So we want to go ahead and look at the metabolic panel can look at electrolyte and abnormality and renal function.
Yeah, so obviously anytime you're prescribing antibiotics, you just must look at renal function. It doesn't even matter what, even if you know you're prescribing something that's not renally adjusted, just look at renal function, because there's so many antimicrobials that require renal adjustment. You're doing yourself and your license a favor by looking at it. So renal and hepatic function, there's less antibiotics that are hepatically adjusted, but it's still, and my dog's back, still important to look at both. Any other labs, Team 10, that you would have ordered not infection related?
I can't think of any. I was concerned a bit about the PICC line. It doesn't say that it could be infected, but then I thought about candida, like a fungal infection, but I'm not sure if I was going in the right direction for that.
Yeah, so patient is on a regimen that we've decided has definitely some possibility to cause neutropenia. Patient has a PICC line, and those are two risk factors for fungal infection. So depending on would we want to hospitalize this patient? Let me ask that question first. Is this someone we would want to admit to the hospital?
I don't have enough data to say that I would admit the patient. I guess I would need the labs back. Well, I have some labs, but maybe more of the other additional labs.
Okay.
Yeah.
So how should I phrase this question without giving it away? So if we were concerned about whether we may have to admit the patient, you ordered a CMP. What other labs could tell us if this was an infection serious enough to warrant hospital admission? And I'll let this any team. We won't pick on Team 10 anymore.
Do we need like the saturation of oxygen or something to see if there's like respiratory issues?
Yeah, so easy to get, low effort. So O2 sat would definitely be helpful. We can identify if the patient's in acute respiratory distress, not fully, but it could help decide if we want to get additional information. Anything else related to ARDS that we would want to potentially draw labs for? Any team? How can you identify acute respiratory distress syndrome?
Are you asking for like the PaO2?
An ABG?
Yeah, there we go. Good job, guys.
Get it when you think about it and you're too scared to answer.
It's okay. You know what? It's all good.
Yeah.
Just try.
So PaO2 comes in an ABG or a VBG, so arterial blood gas or venous blood gas. And so this patient already has a PICC line, so this is easily low effort. Just get some blood and send it to the lab. It can be much more cumbersome to get an ABG or a VBG if the patient doesn't already have access. It does take a decent amount of blood, and some patients, especially I find oncology patients, can be a difficult stick if they've been going through chemo for a while. So we're lucky to have access at this point. So no problem to get that lab. What else? Something that would come in the chemistry section. There's still one thing you guys are missing that would be really helpful to determine the severity potentially of this patient's infectious process. Just one single lab.
Would it be the pH?
pH would come in the blood gas, or you could calculate it from the CMP or the BMP, depending on what you ordered. But pH would be helpful. I'm looking for something else though.
Bicop. Is it bicarbonate?
Same thing that would help you calculate the pH. Something different. Keep trying. Something that comes in a bundle.
As in 2 magnesium molecules or something?
No. Think back a few short weeks to sepsis.
The sepsis bundle?
What's bundle? In the sepsis bundle? What lab value?
Lactic acid?
Yeah, serum lactate. So if that's 2 or more, that would be a sign of sepsis, and then we would want to admit this patient for sure. Thanks, guys, for finally getting there. Yay. Good job.
That's awesome. So there's also one other thing that you haven't learned about yet, because we haven't gotten to bleomycin really in depth with Hodgkin's lymphoma. When you had PDA, do you remember, or actually I kind of just talked about it, what is a particularly bad side effect that can happen with bleomycin?
With the lungs?
Mm-hmm. Right. So I said pneumonitis, right? So pneumonitis also presents as a mild fever, dry cough, chest tightness. So one of the other methods that I might want to just order, just to make sure, because pneumonitis can progress to death very quickly, is to do a chest CT. And incidentally, for COVID-19, some of the data that's coming out of China, they actually found that specifically just for COVID-19, that x-rays weren't really all that helpful at being able to figure out like how badly the lungs were affected. And the nice thing is that we would be able to kind of tease out opaque ground glass of pneumonitis versus the presentation of COVID-19 or even other kinds of pneumonia. So for me, this patient, you're right. I think it was Karen who said, I don't know if I have enough information to admit the patient. My sense would be to admit this patient, at least for a day or two, to do the workup, because you can get a lot of information with the home health nurse. But if there's a chance that the patient has COVID-19 and is neutropenic and is also on a pulmonary toxic drug, I might be worried that this patient could decompensate really quickly. So it would probably be let's bring the patient in, let's admit them, put them in isolation precautions so that we can figure out what's going on, get all the information back. Hopefully a COVID-19 test is available. I'm sure many of you probably know that it's very hard to get tested right now. And especially, for people who haven't traveled or who've had a known sick COVID-19 contact, some hospital protocols are not really allowing for testing. Hopefully that will change when more tests are available. So I would be worried about a whole bunch of things, infectious, kind of all the typical stuff, but I'd also be worried about pneumonitis. So just to give you a little bit of my perspective on that.
Any other questions about the diagnostic and laboratory workup for a patient with febrile neutropenia? It is a bit of a kitchen sink approach in the hopes that you catch the causative pathogen. So be aware that you're probably going to need to make sure every single possible lab is ordered. All right, so last but not least, what kind of regimen? So most of you pretty quickly identified, it seems, that the patient was at risk of a bloodstream infection, as well as potentially pneumonia. Could we maybe get a sound off quickly? How many people wanted to treat the patient as an outpatient? So team 1, in or outpatient?
Um, just like we discussed that we didn't have enough data to admit the patient. Now kind of we changed the mind, but initially we put the patient is at the low risk because no comorbid condition, no renal or hepatic dysfunction, and neutropenia duration is less than or equal to 7 days. So we say ciprofloxacin 750 mg every 12 hours until fever and neutropenia has resolved.
Okay. Team 2, how about you guys? Did you initially treat the patient inpatient or outpatient? No penalties for wrong answers, just curious.
Just addition to the answer given by team 1.
Yeah.
From the lexicon, we also added that first dose should be given in a healthcare setting.
Okay, we'll skip team 2, move on to team 3. How about you guys? Did you initially treat this patient in or outpatient?
We initially treated them outpatient.
Okay. And did you also use a quinolone?
Yes, we did.
And did you choose Cipro or Levo?
Chose Levo.
Okay. Team 4, how about you guys? In or outpatient initially?
We said outpatient.
Oh, team 3, did you have something else to add?
No, I was trying to talk.
Oh.
What? Yes, I was saying we did something as team 3.
Oh, okay.
Yeah.
Did any teams, since let's see, the first couple we've gone through have chosen to treat as an outpatient, did any teams initially choose to treat as an inpatient?
We said initially inpatient because I guess, I don't know, my team's just confused because if the patient is a cancer patient and their ANC is less than 500 and they have a fever, why are we treating them outpatient? Like that, I don't know. We're just like confused why we wouldn't treat them inpatient.
Yeah, so one of the reasons you might consider treating them outpatient is because there's just a whole bunch of nasty bugs inside the hospital. So that's one area where the mask score can come into play, and some of those other kind of risk scoring or mortality calculators, all of those kind of things can help you potentially decide to, if you can keep a patient out of the hospital. That's always positive for infection prevention purposes. And obviously this is a patient who's at a risk of infections at the moment with their neutropenia, because they won't be able to mount an appropriate response to fight off an infection. So that's one reason that if the patient is healthy, potentially low risk, it might be actually safer to keep the patient at home.
So then how do you monitor a patient who has febrile neutropenia and you're treating them outpatient? Like, how do you feel comfortable, like, just sending them home? Like, I get keeping them out of the hospital, but like, how do you monitor that they're fine just being at home?
I'll maybe turn that one over to you, Dr. Levis, since I get them once they're in the hospital.
Yeah, totally. So normally what I do is when I'm evaluating a patient for febrile neutropenia and their risk, most patients don't have the ability to go to home health care or don't have home health. This was kind of an unusual case and it makes it a little bit easier. Most of my patients, what will happen is we'll get a critical lab because they've gone in to get a lab draw. And for ABVD, because we know that it can cause severe neutropenia, it's not uncommon for us to check kind of frequently to see how the patient's doing. So, you know, if the situation happened where maybe I got the critical result before the patient called in, I'd call the patient and check in and say, hey, how you doing? You know, your labs came back, they're low. You know, do you have a fever? You know, do you have any symptoms? And sometimes they won't have a fever, but they'll have symptoms of potentially an infection brewing, right? Because a fever also implies that your immune system is intact enough to mount a response. So there are times where actually patients have like very low temps because they're trending towards sepsis, or they just don't have, you know, a high temperature. In that case, I'll tell them, I'm going to send over a prescription for, you know, Cipro, Levo, Augmentin, whatever. And if they don't have severe enough symptoms to bring them in, and there's nothing else I'm worried about, like pneumonitis or something like that, then I feel like they're okay, provided that, you know, again, they're not having any other symptoms, and maybe also based on how much support they have at home. So if somebody's living by themselves and I'm worried like they're older, maybe there's concern of dementia, anything like that, then that might change my feeling about what I do with the patient. But in general, we try and keep them at home as much as we can because that's usually the safer option. We just have call-ins and check-ins with them. And then we tell them, if you don't get better within a couple of days, or if you get worse, if the fevers continue, then you need to call us back. And then we'll typically have them come in either via urgent care, or we'll do a direct admit if we don't want them sitting in the emergency room, being around all the other sick people. But right now, with COVID-19, it's very hard to get direct admit to the hospital just because bed censuses are very full right now across the country. So I hope that helps. I mean, it really is patient specific, but we do keep a close eye on our patients.
No, yeah, that answers my question. Thank you.
Okay, cool. Oh, Dr. Fox ran away. All right. So are there any other questions from everybody before we let you guys go? Anything that seemed confusing, or do you guys feel pretty comfortable with the scope of what we've covered for febrile neutropenia and neutropenia?
I do.
Awesome. And just, understand again, for test purposes, we are not deviating outside of this discussion at all. Okay. And I don't need you to memorize the, which regimens are considered intermediate or high. I'm going to give you the number and you're going to tell me what that correlates to. That's really the most important thing. And then just understanding if a patient has risk factors, when to give them a GCSF, when to give somebody a GM-CSF.
I have a quick question in regards to the therapy.
Sure.
Do you want to choose Levo over Cipro because since Levo is a respiratory fluoroquinolone? And this could be this person's at risk of pneumonia, right?
Mm-hmm.
In this case, it would probably be wise to choose Levo over Cipro since you have some concerns for a respiratory infection. Many of you identified correctly that you don't quite have all the required information that you would be able to make the best decision because obviously if this patient did have coronavirus, neither Cipro or Levo are going to do anything. Probably no antibiotics are going to do anything, but certainly not quinolones in this case. So it is a bit difficult because the full diagnostic workup hasn't been completed at this point. You're kind of choosing an empiric regimen with maybe a few considerations. So choosing Cipro would probably be wise. I don't think at this point that Augmentin would probably, it might cover what this patient has, but when you consider the PICC line and the potential Staph aureus, including MRSA, that's probably insufficient at this point. So Clinda theoretically could be a reasonable option if the patient had some intolerance to quinolones or previous allergy documented, if you were going to treat the patient as an outpatient. If you were to admit the patient, which again, based on this information, might be hard to make that decision. Again, I think Dr. Leaf mentioned, considering the current times, it might not be unwise to admit the patient. So if you did admit the patient, you would probably look for IV antibiotics that covered MRSA. I think potentially covering for fungal infections would be reasonable considering the presence of the line, and including gram negatives. Presumably the patient showers also, so they could be at risk of Pseudomonas if they're not covering their PICC site well while they're showering, which there are ways to do that, but it can be hard to assess patients' adherence to that and their ability to, do a good job when they're at home on their own. So again, kind of kitchen sinking this patient probably wouldn't be unreasonable choice.
Thank you. That helps.
I just had a question in regards to the treatment with starting with the levofloxacin. Now it was stated in there the 7 to 14 days or until the ANC was above the 500, no longer neutropenic. But there was also a section it was kind of like a flow chart talking about after 2 to 4 days. I don't know if I'm in the right section here. After 2 to 4 days, if you get the culture or whatever, you can reassess and then either continue on depending on the patient's stability or basically, like, let's say it was a fungal infection and, how does that, or is that inpatient only?
No, that could be outpatient as well. It's, again, depending on what cultures you were able to acquire from an outpatient can limit your ability. It's kind of what they're kind of talking about in that flowchart is like the antibiotic timeout concept where, it's been a couple days. Typically, blood culture results aren't considered complete until 3 days have passed. And most labs keep cooking them for up to 5 days because there are some slow growing microorganisms that you can catch after the 3-day mark. But typically they're considered mostly complete by day 3. So what that's basically telling you or reminding you to do is your antibiotic timeout to reassess your therapy and make sure you're covering what you need to be covering, or potentially, if possible, we always like that, peeling back to a more narrow regimen.
Okay. Thank you.
Mm-hmm. Thank you, guys. So just really fast, I'm working on the IRAT for tomorrow. I apologize.